Hi everyone and welcome to our webinar. Today we're going to be presenting on everything you need to know for MIPS 2022 and beyond. My name is Chelsea Grover and I'm the Marketing Manager for DAS Health. Before we get started on today's webinar, I want to take a moment to explain the process for the presentation. First, I want to mention this webinar will be recorded, and also, yes, we will send out a copy of the slides and the recording within the next week. Next, I wanted to remind you of some super exciting news. iTenev is now part of DAS Health. Now, it looks like we have a good mix of current DAS Health customers as well as those who came through us through iTenev. So I'm going to do a quick rundown of who we are at DAS Health, just as a refresher for those who don't know. DAS Health is a leading provider of health IT management solutions and a trusted consultant to many physicians groups, hospitals, and healthcare systems across North America. By combining our skills and expertise, we'll be able to provide even more support, value, and solutions to your practice. We're looking forward to continuing to serve you. This month, you'll see iTenev transition out of using their name, email address, and social media channels to the DAS name. So please, please, please start using us and following us at DAS Health to keep your eyes out for those new emails. And next, I want to reassure you that we are still here for you. We're still going to be here specializing in NextGen and keeping our focus on you. We're still passionate about providing solutions for healthcare provider partners, which in turn help them to improve patient care, enhance the patient experience, and maintain a financially healthy practice. We also now have support for Aprima, EMD, Metasoft Clinical, YTech, and AthenaWorks, just to name a few, along with our offerings for patient care solutions, information technology solutions, hosting, and government incentive reporting. Okay, so this time we're going to try out something new for our upcoming webinars. We want to hear from you. We want to know what you want to learn more about. So please take a moment to look at your screen and check off any topics that you would enjoy seeing webinars on in the future. And no guarantees of when we're going to get to them, but we always are looking for more feedback so that honestly, we do these for you. We enjoy making them too. Well, at least Lindsay definitely enjoys making them.
Absolutely.
Lindsay does love her government incentive programs. But please check off any that you think that you'd be really interested in learning more about, hearing more about. Maybe getting into the nitty-gritty details. If you don't see it up there, please either use the chat box or the questions just to shout it out there, whether it's a 101 or super detailed something on blah, blah, blah. That's why we do these, so let us know. And it looks like most people will give everybody about 5 more seconds to do this. And if you think of something throughout the webinar, feel free to drop it in the chat box then to let us know as well. Okay, so with that, Lindsay, do you want to close the poll? You want to show everybody how they stack up against others? So it looks like more MIPS, please. I think we'll be able to do that. So Lindsay, you should be happy about that.
Let's say we got the right audience.
Yep, it looks like EHR specific MIPS content, and along with everything else. So thank you everybody who responded. And again, if you think of something specific, go ahead and drop it in the comments, and we'll be sure to do it. We'll be sure to add it to the list. Okay, so back to today's webinar on everything you need to know for MIPS 2022 and beyond. At the end of the presentation, we'll open the floor up to questions from you. We're going to answer all the questions at the end, but you can type them in the questions area of the webinar control panel whenever they occur to you. And finally, for audio clarity purposes, everyone's phone will remain muted throughout the entire webinar. If you experience audio issues, please use the chat box to let us know so we can resolve them. And again, questions may be asked in the questions box. So without further delay, I'd like to introduce our presenters for today. Lindsay Lanning is going to be doing much of the presentation itself, and she is our Government Incentives Manager. And then we also have Bridget Peterson, who's our Government Incentives Assistant Manager, and Kimmy Watson, who's our Government Incentives Assistant Manager as well. They both have heavily helped to contribute in the writing of this and are also going to be helping with questions at the end. So this is their first webinar with us, so we're really excited to have them, and I'm sure that you guys are excited to hear a new voice besides Lindsay's. So with that, I'm going to go ahead and turn it over to Lindsay.
Perfect. Thank you, Chelsea. And I think everyone's just super excited to hear me present again. But in all seriousness, thank you everyone for joining us on this Thursday afternoon. We are so excited, and that is not sarcasm. We actually are excited to be here today and to go over the MIPS program requirements for 2022 and look at what CMS has proposed for 2023 and years after that. So as Chelsea mentioned, you have your entire government incentives team on today, myself and both Kimmy and Bridget. And I know we see a lot of familiar names out there and some new ones, so welcome all. Our plan today is to try and relay to you all what's required under MIPS for 2022 from a need to know perspective. If you know any of us, we could talk about MIPS for hours, and I mean hours. I'm pretty confident I could perform a record-breaking filibuster on MIPS if someone let me. But that's besides the point. What I'm trying to say is that this is our full-time job. There is a whole team of us here at DAS Health whose full-time job it is just to understand this program completely and thoroughly. And I know many of you on here are responsible for MIPS at your practice, and I'm going to guess it's likely not your full-time job. So we're going to do our best to have you walk away feeling more confident that you know what you need to do, this year in 2022, and you also understand and know where the program's headed in 2023 and beyond. So let's go ahead and get started. I will preface this saying, as we look at what's new for 2022, we are going to provide, somewhat of a baseline or a fundamental layer, I'll call it, because in order to understand what's changed, we have to understand what was in place, in the first place. So if you're a MIPS vet or a seasoned participant in the program, we do have some introductory slides on the program. They may seem a bit repetitive, but fear not, we will get to the new stuff and pretty quickly since we have so much content today. But again, enough of the intro, let's just get to it. So let's start with a quick vocab lesson. While most of us throw out the terms MIPS or MACRA or quality payment program as kind of somewhat interchangeable, they're really not, and they do mean different things. So to clarify, for the sake of the rest of the presentation, let's break this down. So the quality payment program, or the QPP, was actually enacted under the Medicare Access and CHIP Reauthorization Act of 2015, or MACRA. As you can see, the quality payment program is comprised of two participation tracks, either the merit-based incentive payment system, or MIPS, which we're talking about today. This is where clinicians receive a performance-based adjustment, or alternatively, see what I did there? We have the advanced alternative payment model track, which are the innovative payment models that really have their own unique program requirements, and those clinicians receive a lump sum incentive. So when you think of APMs, things like CPC Plus, Medicare Shared Savings Programs, any type of ACO or accountable care organization, things like that. So breaking this down, we have MACRA that created the QPP, and you can report under the QPP either under MIPS or APMs. Simple, right? Now, the traditional MIPS track was developed to actually improve patient health outcomes by tying payments to quality and cost-efficient care, with the intention to increase the use of healthcare information and reduce the cost of care. So I know, firsthand, our team knows that MIPS sometimes gets a bad rap, that it's just another set of requirements and it's more clicks or burdensome workflows. And I hear you, but at its core, this program does work to improve patient care and patient outcomes. If MIPS were a person, I would say they have a really good heart and it's the thought that counts. There's really good intention there. In reality, what this program did was actually consolidate a bunch of legacy programs that we reported on into one. So they say loan consolidation is a good thing. Why not program consolidation? Horrible joke, but you get the idea. So MIPS actually took the old PQRS, or the Physician Quality Reporting System program, the Value-Based Modifier program, or VBM, and the legacy meaningful use programs and put them all into one. And we'll look at how they did that in a few slides. Now, what's important to understand is the timeline for MIPS. So you have your performance year, which aligns with the calendar year, making it pretty simple. Then you submit your data for that performance year, which takes place in Q1 of the following year. CMS is going to take that data that you submitted and score it and make it available typically in Q3, normally August of that following year. And then based on that score, you get a payment adjustment. And that adjustment is going to be applied on a claim-by-claim basis for the entire next year. So you can see, I think, with this graphic, the reason for the 2-year lag between your actual performance and then, the payment or the adjustment payout. So you report for all of 2022, and then you're going to submit your data in the first quarter of 2023. Then CMS is going to take a few months to score this. So, everyone across the country, has their scores in and they need to figure out what the payment adjustments are. And then you'll get that adjustment in typically August. You'll have a few months to contest it if there's any issues. And then that's why the payment adjustment is actually applied the next January, which would be 2024. Now, a crucial part of this program is that not every clinician is actually eligible or required to report under MIPS. There are certain thresholds you have to be over in order to be required to report or even to be able to opt in or volunteer to report. So for the sake of a need to know, we're not going to go into that detail right now, but there is a simple way to check if you're eligible. It's what's called the QPP NPI lookup tool. It's what our team uses when we assist clients with MIPS reporting. So this is actually found on the Quality Payment Program website, which is the most helpful and informative website CMS, I swear, has ever created. They really got it right with this one. And I can't stress enough, not only does this website have this lookup tool, but it has so much more, including a resource library, which is very helpful. Now, when you search an NPI, it's going to come back and show you if a clinician is included or exempt. It's going to show, their clinician details listing their provider types and any associated tax IDs, and then finally the practice level details. So the practice detail section is actually where we're going to find or see information on if your clinicians have any associated special statuses. And it also gives you a practice versus individual breakdown, which you might be asking why. Well, clinicians are actually able to report under MIPS two ways, either as an individual or using the group participation method. So if you report as an individual, you're going to report under your NPI, tax ID, or TIN unique combination. And that you're going to get a unique score applied, just to your NPI. Now, if you report as a group, you're actually reassigning those rights to your tax ID or your TIN. So you would actually only submit one data set that aggregates all the data from your TIN. So it includes, all the NPIs under that tax ID, and everyone's going to get the same score and the same adjustment. Now, there is a third option of a virtual group, but again, in the spirit of, need to know, these are the two main reporting mechanisms under MIPS. Now, your next logical question would be, well, what are we reporting on? And it goes back to those legacy programs I mentioned. So under MIPS, you're required to submit data on 4 different categories. You have quality, promoting interoperability, improvement activities, and then lastly, cost. So the quality category is basically the old PQRS program. This category is going to consist of quality measures that you can think of, like documentation of current meds, blood pressure, screening and follow-up, tobacco cessation screening and follow-up, couple up with that, depression screening and follow-up. There are specialty specific ones as well. I'm trying to think diabetes, eye exam, et cetera, might ring some bells for you all on the line. The PI category is actually the old meaningful use program. And it's going to contain measures that you're used to, like e-prescribing or tracking patient portal access. And then we have improvement activities. This is actually the only category under MIPS that did not stem from a legacy program. It's completely new. And then you have cost, which is the old value-based modifier program. So these measures are going to focus on spending and utilization for your practice. So these categories are what control your score. Each one has different requirements and their own scoring complexities, and this is what our team works with you directly on to improve your scores. So let's take a quick look at what each category requires from a very broad bird's eye view. So you get an idea, and can really better understand the changes for both 2022 and 2023. So the quality category is reported for a full year, meaning January 1st to December 31st. We're tracking that data for a score the entire year. The category itself is worth 30% of your MIPS final score. And there are, a total of 200 plus measures right now to pick from. You only have to pick 6 to be scored on. And one of those 6 does need to be an outcome measure or a high priority measure if an outcome measure is not available. Now, when you have your top 6, you need to make sure that each measure meets what's called data completeness, which means your group submitted data on 70% or more of the patients that meet that quality measure denominator criteria. So, for example, if you saw 100 patients the whole year, not likely, but hear me out, it's the easiest math. And you were reporting on documentation of current medications, you would need to submit data on at least 70 of those 100 patients to CMS for the measure to count. Now, again, typically this isn't an issue. Most practices submit data on all of their patients, but just calling this out so you know what this data completeness threshold is and what it means. And last but not least, is kind of a glimpse into the scoring for these measures. Gone are the days for any of these categories, really, that if you kind of hit a certain percentage, you would quote unquote pass the measure. I'm sure you remember that from meaningful use days. Now you have to score as high as possible on every single measure. And how many points you get for each one in the quality category specifically will actually depend on the measure's benchmark. So I think we're all familiar with the concept of benchmarking, but in this specific scenario, you're going to look at your performance percentage or performance rate on your report and then compare it to the benchmark CMS has created for that measure. And that benchmark is going to tell you how many points you earn out of 10. So this complicates things massively because a 100% on one measure may only earn you 7 points, but a 65% on another measure might earn you the full 10 points. So you can see why it's so difficult to understand your own data now, because you can't just look at your report and pick the top 6 with the highest percentage. It's now all about the benchmarks. And don't even get me started on if there isn't a benchmark or a 7-point cap, because again, I really won't even get started or we're going to be here all day. So next is the PI category. This category is going to require submission on data, specifically for objectives, unless an exclusion is going to be claimed. But these need to be submitted for the same continuous 90 days or more. And it's going to be the e-prescribing, health information, provider to patient exchange, and then public health and clinical data exchange. So I think number one's pretty obvious, e-prescribing, doing those prescriptions electronically. Number two does actually have 2 measures within it. They focus on sending and receiving referrals electronically. Number 3 actually focuses on access to the patient portal and sharing data with patients. And then number 4 focuses on reporting data to an external source, whether it's a public health registry or a clinical data registry. The big difference here is that this category only requires 90 days worth of data, not a full year like quality, and it's worth 25% of your final score. It does also require the use of certified EHR technology, or CERT, which I'm sure all of you on this call have heard of and are likely using. And we'll get more into each one of these measures when we look at what changed in 2022. So again, just trying to set the baseline here. Next is improvement activities, or what I'll kind of refer to here as IA. So IA is worth 15% of your MIPS final score. And it also requires a minimum performance period of any 90 continuous days, within that calendar year. And no, let me just kind of jump in front of some questions here. This 90 days for improvement activities does not need to match your PI 90 days. And no, your 90-day reporting period does not actually need to align with a quarter. It can really be any 90 days. You could start at May 8th if you wanted. Now, there are 100 plus activities to choose from, and that's really what it is. It's just a list of activities for you to review and select ones that you're currently doing to get credit. So there's no data for this category. It's just a yes attestation, which again, you should have documentation to back it up in case you get audited. So each activity contains a weight. Medium activities are worth 10 points and high weighted activities are worth 20 points. And the maximum score for this category is going to be 40 points. So, you can do the math. You can do any combination of these activities you want to add up to 40 to get full credit. Now, if you're a small practice, if you're considered non-patient facing, or if you're a clinician located in a rural or healthcare professional shortage area, the weights of these activities actually double, meaning the high weighted are worth 40, medium are worth 20. So this is going to essentially cut your reporting responsibility in half for this category. And again, to jump ahead of some questions, you would be considered a small practice if you're under 15 clinicians. And these statuses would all show up when you use that NPI tool. I covered a few slides ago. The data that you'll get back will show you if you have any special statuses. And then last is cost. So I may not have realized it actually, but I listed these categories in almost hardest to easiest order based on practice burden. I say that not because cost is super easy by any means. It's not easy to get a high score here, but because it's the easiest category administratively on your practices, because you don't submit any data. CMS gets your cost data from administrative claims that you submit to CMS for payment. So this category is going to be worth 30% of your MIPS final score, and it is being tracked for an entire year. Now, there are two main measures, which are Medicare spending per beneficiary and then total per capita cost. And then there are 23 episode-based measures that depend on the type of care you provide that could be included as well. And in order to be scored on a measure, you have to meet what's called the case minimum for that measure. So CMS, to give you an idea, typically has a minimum close to 20 to 35 patients for each of these measures that have to qualify for you to be scored on. So as of now, we actually don't have any visibility into your cost performance throughout the year. You just get feedback after the year ended on how you did. Okay, so now that we all have the same baseline, kind of to go off here as we review this year's changes, let's look at what's different under MIPS and what you need to be aware of since it's happening right now. Okay, the biggest change, performance thresholds, and this one is a doozy. So for 2022, the threshold to avoid a penalty is 75 points, which is an increase of 15 points from last year. This number is the highest it's ever been. Obviously as each year, it's increased. And then for 2022, this threshold, they actually created it. They didn't just pick 75. It was actually based off the mean or median of the final scores for all MIPS clinicians in previous years. Obviously, scores were a little bit higher in previous years because can you remember back in the days when you just had to submit one data point or just improvement activities to get full credit here? But that is where this number is coming from. The other threshold, we're worried about or we track each year is the exceptional performance threshold. So this is the threshold you want to be above to guarantee your practice and incentive. If you remember way back when, again in 2017, when MIPS started, CMS set aside $500 million for the first 5 years to distribute to providers who they called exceptional performers. So this means, unfortunately, 2022 is actually the last year to take advantage of this added financial bonus. It actually expires after this year. And to take advantage of it, you have to score an 89 or above this year. So what do these payment adjustments look like for MIPS for 2022? Well, we have to factor in that MIPS is a budget neutral program. What that means, the penalties are what fund the incentive payment. So in order to have a high reward, you're going to need some pretty steep penalties being doled out as well. Now for 2022, scoring and max penalties are fully implemented. This means we are looking at a negative 9% penalty that would be applied to your practice's, overall Medicare reimbursement for a year if you were to earn a 0 to 18.75. That means if you don't participate at all, or even if you maybe only submit your improvement activity data, you would be looking at the full penalty, again, for an entire year on your Medicare Part B claims in 2024. On the flip side, based on CMS's calculations, they expect up to an increase of 14% for a positive payment adjustment. Now, I'm going to be honest with you. There is no chance we see a positive 14% payment adjustment. If we did, it would make my job a lot easier because I think everyone would be running to us for help to take advantage of that. But this year, there really isn't any way. However, I will say I do think we could see an increase from more than the 1 to 2% we've historically seen. And again, this is only going to get larger each year because the program is going to continue to get harder and more people will be actually penalized, unfortunately. So, you definitely want to be on the opposite side to be able to get a piece of the pie on the positive payment adjustment. Now, besides the thresholds, what are the other major changes we can expect this year? Well, there is the inclusion of new eligible clinician types. So each year they keep expanding this to include more. This year, we've added clinical social workers and certified nurse midwives. We do see the removal of both end-to-end and high priority bonuses for quality reporting in that category. In PI, there's actually been several measure additions and updates. We're going to see some new episode-based cost measures, and then there has been a further delay of what's called the MVPs or MIPS value pathways. And again, don't worry, we're going to explore each of these in greater detail if you have any questions on what any of them mean. Again, on the flip side, what didn't change? Well, eligibility. We mentioned the low volume threshold to determine if a clinician actually has to report under MIPS, which that lookup tool will tell you. But those requirements haven't changed. They're the same. If you still have to bill over $90,000 in Medicare Part B charges, see 200 plus Medicare Part B patients, and provide 200 plus covered professional services to actually be included and eligible for the MIPS program individually. The categories. Now you might be thinking, this is low-hanging fruit, Lindsay. Really? You're better than that. And to respond, no, I am not. But to be fair, we did have a name change for the PI category in multiple years. Anyone remember advancing care information? So I'm going to go ahead and say it would count. But yes, we were stretching here for what didn't change. And then last but not least is the data completeness threshold for quality. So this is staying at 70% for 2022, which we already explained what this was earlier. So let's start to look at the category changes for 2022. First are the weights, or the amount each category contributes to your final score, because they're not equal. You can see there was actually an increase in cost from 20 to 30%. This was actually 0% the last few years due to COVID-19. But this is where we're at now in 2022. And then, as a result, to keep things even, quality decreased. So that actually went from 40% to 30% this year. And improvement activities and promoting interoperability have pretty much stayed consistent. Now, I would like to highlight a crucial shift in the program this year, now that we have covered both the thresholds and the updated category weights, and all at the same time provide a remedial math lesson for you all. For 2022, the threshold to avoid a penalty is 75 points. The weight of the cost category, which we have no visibility into performance-wise, is worth 30 points. That means even if you get a perfect score on all the remaining categories, you get a perfect score on IA, PI, and quality, you would only be earning a 70 out of 100. What this means is gone are the days of us heading into submission knowing that you're avoiding a penalty. Basically, all certainty has really left this program starting in 2022. The stakes are much higher. Also new this year is a special weighting for small practices. Again, small practices 15 or less. But since small practices are actually automatically exempt from PI reporting, that category itself, that 25% would be redistributed to quality historically. Now what they've done is actually split it between quality and improvement activities. So again, if you're part of that small practice, you're not reporting PI, your quality and improvement activities are going to be worth a little bit more towards your final score. And just to pause and kind of take a step back, and let's look at the category weights from the program, since its inception, 2017 to 2022. You can really see the trend here as cost gets bigger and bigger and quality gets smaller and smaller. And then, improvement activities and PI really staying the same over the last 5 years. Okay, so let's dive into each category kind of in the same way we set the foundation to identify exactly what's new in 2022. On the housekeeping side of things, we're going to start with quality. CMS basically made substantive changes to 87 existing quality measures. They did make some changes to specialty sets. They did remove 13 measures, and they did add 4 new measures this year. Now, one thing to watch out for is when substantive changes are made to measures, they may take away the benchmark for a year or two until enough clinicians actually submit data on that revised measure specification to create one. So when I see that high of a number being changed, it does spark some concern. Now they're not going to do this for all of them. It just depends on what those changes are, but that's a large number. One of the biggest changes, if not the biggest change this year, that's impacting our client scores are the removal of the bonus points in this category. So both end-to-end reporting and reporting an additional outcome or high priority measure bonus points are gone. It used to be if you submitted extra measures that were labeled as outcome or high priority, you actually earned 1 to 2 bonus points for up to 6 points added to your score. You also used to get bonus points for submitting measures in a way where manual manipulation of the numbers was not possible. So think, if you submit your data via your EHR or maybe a certified registry, you were getting a bonus point per measure up to 6. So this means that you're losing 12 points in this category this year, which combined with the increase in difficulty and the removal of benchmarks is making a perfect score in this category. I mean, near impossible at this point. Now, luckily, if you're a small practice, they will still provide the 6-point bonus that you're used to, in quality specifically. So again, if you're a small practice, you do still have a little bit something added to your score, but only 6 points. Small practices were used to getting 18 points added to their category score here. CMS is also making some changes to quality performance scoring for this year. So there is going to be a 7-point floor for any new measure in their first year in MIPS, and then a 5-point floor for new measures in their second year of MIPS. This is a win in my book, since obviously as they introduce new measures, there's an incentive to report on them, because think, even if you have a 5% performance rate, you're going to earn 7 points if it's brand new. And I know technically these aren't changes, but it is a good thing to note that CMS plans to continue some of the scoring policies they had from 2021. So any measure that meets the case minimum and data completeness and has a benchmark is going to receive anywhere from 3 to 10 points. Measures without a benchmark will still earn 3 points. And then measures that don't meet the case minimum really just means that you have over 20 in the denominator. If you don't, you're still going to earn 3 points. And I would say a very big win this year was a clarification kind of slipped into the final rule on group reporting. This was brought to light due to the COVID-19 hardship being made. The COVID-19 hardship did have some nuances in reporting it allowed, as well as instances where a practice, it's very possible all of your clinicians may be individually exempt, but you're eligible to report at the group level. So looking at this scenario, if that's the case, and potentially you were submitting quality data via claims, there was a concern here that CMS would think you were trying to report when you might not have been, and they would score you in the quality category when you didn't want to be. So CMS clarified they're only going to calculate a group level quality performance category score from claims measures if your practice also submits data for another performance category as a group. They're going to take that as you signaling your intent to participate as a group. So no real changes per se, much more of a much needed clarification. So next is PI. There were a significant amount of changes in this category from 2021 to 2022. I already mentioned the clinical social worker and certified nurse midwives, being added here. They will be exempt from PI for their first year. The next one I would say is more of an FYI when you go to submit. So CMS actually revised the prevention of information blocking attestation statements. The point behind this is to distinguish this attestation from the separate information blocking policies that the 21st Century Cures enacted. So now this attestation has been renamed to actions to limit or restrict interoperability. So just if you see that, that's that old attestation. And then they did revise the entire public health and clinical data registry reporting measure. So as a result of COVID-19, they now made immunization reporting and electronic case reporting mandatory. And all the other options like syndromic surveillance, or maybe you participated in a specialty registry. I'm trying to think, Pinnacle, Iris, a wound care registry, etc. Those are now just eligible for bonus points. So you can see the changes reflected in the points breakdown here. And what to note is that even if you had one extra registry, so let's say you were reporting to Pinnacle, or you had 4. So let's say you were reporting to Pinnacle. These are all specialty specific, so this would never happen, but you're reporting to the Regent registry and Iris. You're only going to earn 5 bonus points no matter how many you have. It's either 1, 2, or 3. Doesn't matter. 5 points is the cap. Now, since I think we're all familiar with immunization reporting, if you administer immunizations at your practice, you're going to need to report that data to your state. It's been around for years now. Our other mandatory measure now, this electronic case reporting, or I'm going to refer to it as ECR, I don't think many of you may know about. So ECR is actually not new. It's been around for years, but not many practices have reported on it. So what this is the automated generation and transmission of case reports from your EHR to public health agencies for review and action based on the conditions diagnosed and treated by your practice. So starting with 2022, clinicians participating in MIPS, in the PI category specifically, are required to report this ECR as one of the 2 required measures under this objective. Now, this is going to be state specific, so the conditions required to report will vary by state. And if you have multiple locations in different states, it's going to vary for each site. Now, you do have exclusions for this measure, and for 2022 specifically, there's actually a special one. If your EHR is not certified to send that ECR data, then you can exclude. Again, this is going to be only valid for 2022 though. Now, our recommendation or kind of our process for this new measure is kind of giving away some secret sauce here, but we want to help you all out and really understand this. Our first step is to determine if your EHR is certified or not. If it's not certified, you can take the exclusion. If your EHR is certified, we then recommend going to your state electronic case reporting website. And to find that, try and use our very formal scientific process of Googling your state name followed by ECR, electronic case reporting. It's exactly what we do. If you can find a conditions list on your state website, because most states that I've seen, I don't know if we've hit all 50 yet, but your state's going to have a website with it. You're trying to look for what's called a conditions list and download it and review it to determine if you diagnose or treat any of the conditions on there. This doesn't include, documenting a condition because of a patient's history. This is if your practice is directly diagnosing or treating any of those conditions. If you can't find this list, there should be some form of contact listed on that page, email, phone, etc., to reach out to them, and you want to request a conditions list. Once you review this list, it's our understanding that if you don't diagnose or treat any of those conditions, you can exclude. And if you do, if you do actually diagnose or treat any conditions, we would recommend you reach out to your state and ask if they're accepting data on those specific diagnoses that apply to you, since what we've actually found is that most states are only accepted COVID-19 data right now. And if you don't diagnose or treat COVID-19, then you can then exclude. So, again, if your state's not ready, you're going to be able to exclude and you have that documentation for your audit. If you cannot exclude, for instance, if you're a PCP in New York, because they are totally ready, I swear New York State has been ready for years, you're going to need to be enrolled or at least start the process of enrollment within 60 days of the start of your PI reporting period. So this cannot be an afterthought. So again, if you thought you were done with PI and you were planning on using your Q1 numbers because they look great, but you didn't figure out in time if you could exclude from ECR and you're actually required, I'm sorry, but you can't use Q1 anymore. You got to get enrolled within 60 days of the start of your PI reporting period or beforehand. Now, CMS did add a new required but unscored attestation measure in the PI category. It's called the High Priority Practices Guide of the Safety Assurance Factors for EHR Resilient. Try and say that 5 times fast. We're just calling it the Safer Guides measure, and this started this year. So these guides are from the ONC. They're basically a set of kind of checklist-based self-assessments. It's a tool that's meant to, optimize the safe use of EHRs. The ONC actually published 9 of these guides that cover a range of topics. However, historically, these guides weren't being used. There was no mandate to use them. So CMS is now requiring clinicians reporting under MIPS in the PI category to complete one of these guides. It's the High Priority Practices Guide. So again, only one of these guides, not all 9. Now, this High Priority Practices Guide actually consists of 15 recommended practices, and there's a worksheet for each one of these practices that'll outline things like suggested sources of input, ask you to do an assessment and provide examples of things and action items to resolve any issues. So it's a pretty straightforward, it's a PDF you would complete, and I would say it definitely has some overlap with your security risk analysis. Now for 2022 only, since it's the first year, they're gonna accept a yes or no attestation. So we can't say this measure is optional because it's not. You have to attest. You're just able to attest no this year. Now, what we recommend is to at least review the PDF. You try and assign an owner for the assessment, or at least start evaluating your practice policies and procedures and maybe your clinical workflows with respect to each one of these practices. Try and solicit different input. Think you're probably going to need clinical, administrative, and likely IT. So again, just start the process to either attest yes, or even if you're attesting no, to really kind of get the juices flowing and figure out what's needed next year. Now, with all these changes happening under PI, I do want to remind you, again, if you're a small practice, you're not required to report PI. You have an automatic exemption. However, there are instances when reporting PI would actually benefit your final score, even if it's not required. So as you can see in this example, if your PI score is going to be higher than your quality score, you're going to want to submit that data for an overall higher composite score. So even if you're a small practice, we still encourage you to review the data and stay up to date on these changes, since based on the changes we already went over with quality, your PI could be crucial in increasing your score for the first time this year. Okay, so the last two categories are relatively quick updates for 2022. So for IA, we have 7 new activities added. We've modified 15 activities. I don't know why I'm saying we, CMS, but you get the idea. And CMS has removed 6 activities. One that I'd like to call out that I know we've had clients reporting on in the past is this collection and follow-up on patient experience and satisfaction. So think if you were using the improvement activity for patient surveys, this one has been removed for 2022. So no large changes here, kind of just some standard housekeeping annual updates. Along the same lines for cost, there are new episode-based cost measures. So they've added 5. 2 are procedural measures focused on melanoma resection and colon and rectal resection. There's 1 acute inpatient measure focusing on sepsis, and then 2 chronic condition measures. Those are going to be focused on diabetes or asthma and COPD. So if you treat any of these conditions or perform these procedures, this may impact your cost score if you meet the case minimums for them. All right, so we've made it to our kind of last leg here for the 2023 proposed rule changes. That is it for 2022, or our current year requirements and their updates. Now we're going to focus on next year. And okay, you notice I highlighted proposed in the previous slide. So first and foremost, I'm going to have to make this distinction. What we're about to review is proposed. It is not final. Every summer, CMS issues a proposed rule, typically it's in July, and it includes changes to the Medicare physician fee schedule and quality payment program, both lumped into one. Basically, CMS gets public comments back on this, and then they release a final rule. Typically, it's been in November each year. Last year was actually December. So what we're going to cover in this section is actually the proposed changes for the 2023 QPP program. However, we're not going to know if these are final for sure until later this year. So just kind of forewarning you on that. So the rule itself actually is going to include much more than MIPS updates, what we're worried about. Obviously, our primary focus is going to be that, but we did want to point out some important things here. So this rule does actually propose to cut the conversion factor for the physician fee schedule to $33.08 for 2023. So to give you a comparison, it was $34.61 in 2022. So with this information, we now know there is actually a potential 10% cut in Medicare physician fee schedule reimbursement in 2023. And this is a culmination of previous pieces of legislation as well. So you had a 2% sequester cut from the Budget Control Act in 2011. Then you had a 4% sequester cut that was scheduled, starting in 2023 from the PAYGO Act in 2010. And now you've got this 4.4% reduction from the conversion factor that's been proposed. So as expected, Congress is receiving a lot of feedback. This is not something CMS or other agencies have any hand in. This is all pending congressional action. So we will see what or if there's any future, rulemaking this year to combat this reduction. But you can see why earning a positive payment adjustment under MIPS would be a huge help in offsetting this, in future years. Another quick note before we look at the MIPS specific updates for next year is the other track under the QPP, the APM updates. There's a bunch of notable updates, but I really wanted to point out one, since I'm sure a lot of you on the call have providers in both MIPS or maybe in APM agreements at hospitals or just potentially different locations. So the 5% lump sum bonus for any provider that achieves what's called QP status in an APM expires in 2022. Meaning if you're in an APM in 2023, there's no bonus. Now, you still get the benefit of being exempt from MIPS, but as it stands, there's no positive payment award for this track under QPP next year. So I wonder if we're going to see a lot of providers switch back over to MIPS, to try and earn an incentive, which is the exact opposite of what CMS wanted. So again, this is not controlled by CMS like you would think. This was written into the law and is actually controlled by Congress. So again, a lot of decisions for Congress to make, this year that are going to impact directly payments to you all. So we're going to be keeping a very close eye on this. Okay, so back to our what I'll call regularly scheduled programming of MIPS updates for 2023. So let's start in the same fashion as our 2022 updates with threshold and category weights. You can see from 2022 to 2023, there are no changes. This is the first time in the history of the program that there were no changes in weight or thresholds or penalties. So this signals to me two things. One, admission that the program is extremely difficult in 2022. And two, this program is fully implemented. All the transition items or perks that were kind of built into the program for the first few years that helped us along, like bonus points in the quality category, are, for lack of a better term, as Justin Timberlake would say, dead and gone. But in all seriousness, this was a shock, a good shock, since we don't want these to get any harder. But this is absolutely the first time we've seen, no change in here or no increase. Now, if we follow again that same format and quickly look at each category, for quality, you can see it is mainly just housekeeping items. You're at a total of 194 quality measures. That's going to include 9 additional measures. Again, think of the perk with new measures with those new floors put in place of 5 or 7 points. One of those new measures that I wanted to call out is actually screening for social determinants of health. So that's a new opportunity. There were substantive changes to, again, 75 existing MIPS quality measures. Again, one I wanted to call out is actually the influenza vaccination measure. Typically, the reporting period, started from October to December, and then again, January through March. They actually proposed to start tracking in July versus October. And then they're proposing to remove 15 quality measures. Again, one of which I know we have, a decent amount of clients reporting on is the diabetes medical attention for nephropathy measure. And then they have a partial removal, and that's 2 quality measures. So they're removing these measures from MIPS, but not MVPs. And we'll talk about MVPs next, but these are huge because I know we have a lot of clients reporting on these, but actually the influenza and the pneumococcal vaccination measures are being removed as options to report on for MIPS, unless you report on the MVPs or MIPS value pathways options, then you can report on them. And then there was an increase in the data completeness from 70% to 75% for years 2024 and 2025. So I wouldn't say there's any huge changes, but there are ones to be aware of, especially if you usually report on any of the measures that I mentioned that are going to be removed or have changes. So for PI, they're proposing to make the prescription drug monitoring program, or the PDMP, mandatory. So this is when your providers are prescribing a controlled substance, they would look the patient up to make sure they don't, they're not getting this prescription anywhere else, or they don't show patterns of drug seeking behavior. Currently, it's actually worth 10 bonus points. They're proposing to make it mandatory. There's also a proposition to add another option to the health information exchange measure for full credit, which would be participation in TEFCA. I'm sure if this is finalized, there are going to be many more details to come. And then last but not least, there were updates to scoring and measure point values. So you can see those changes here with the comparison from 2022 to 2023. Most notably, health information exchange and portal did decrease, and then public health and clinical data measure, that point value did increase. Now, the biggest change, what I would call out for 2023 is going to be under PI, and it's the requirement regarding certified EHR technology. If you can remember years ago, everyone had to upgrade their EHR to be on the 2015 version. Well, here we go again. There's a new version called the 2015 Cures version that's going to be required for participation in MIPS starting in 2023. Now, there's some confusion around the deadline of when this version is actually required to be in place. The regulation itself says December 31st of 2022. However, it really depends on what quality reporting initiatives you're participating in. So if you're only participating in MIPS, you actually only need this in place before your PI reporting period, and that's 90 days. So that means at the absolute latest, you need this version in place by October 2nd of next year. And if you happen to be a small practice and you don't have to report PI, then you'll only need it in place by December 31st of next year, and that's for quality reporting. Now, if you're on the APM track, this is where things might be different. Each APM, so again, CPC Plus, Medicare Shared Savings, ACOs, they have their own requirements for when this certified EHR technology has to be installed. And I've seen ones that say January 1st, 2023. So if you report under an APM, please make sure to reach out to your reps or contacts there and ask what's needed and when. And if you are wondering if your EHR is certified to the 2015 Cures or what version of your EHR should be, you can look it up on the Chapel website that I linked here. You can just search your EHR vendor and get this information. You can see I searched NextGen here, and you can see which versions are 2015 versus 2015 Cures. And then we have the IA category. Again, more housekeeping here. We added 4 new activities, modified 5, and we did remove 6. 2 that I'll call out. One is the leadership engagement. We do have clients reporting on that one. And last is the PDMP. This makes sense. If it's going to be required under PI, CMS isn't going to let you get away with double dipping. That would be too easy. So they would then remove this activity for credit. And last but not least is cost. So CMS basically is just proposing to establish a maximum cost improvement score of 1 percentage point. So no major changes there. Okay, so did you notice how much quicker we went through the 2023 changes versus 2022? No, it's not because we're almost up on time and I had a choice. It's actually by design. CMS made a comment that they were purposefully not making any big changes in 2023 for MIPS because they want providers to prepare for the new MVPs pathway. Now, I will argue CMS's definition of big changes is a bit different compared to the ones who actually have to report on the measures, but again, this is not my filibuster. So, as promised, let's look at what is this MVPs, they want everyone to prepare for. Well, they're called MIPS value pathways, and apparently they are the future of the program in CMS's words. Now, we're going to keep this brief, and I mean brief, but basically MVPs are going to, become, gradually available starting in 2023. Which in theory, it's supposed to allow practices time to review the requirements, update their workflows, and prepare, as needed to report under this new pathway. So this framework tries to, really align and connect measures and activities across all the performance categories based on your specialty or conditions you treat. So I wouldn't call, it a true program overhaul or revamp. It's more of a restructuring in the way MIPS would work. So to report an MVP participant is actually going to register between April 1st and November 30th of their performance year. And then you wouldn't be able to submit or make any changes to your MVP selection once the registration period has closed, which would be November 30th. And you won't be allowed to report on an MVP if you didn't register for it. So think of it as putting your name in the goblet of fire. There are no takebacks. So for 2023, 2024, and 2025, CMS is going to allow clinicians to report in various ways, individually, specialty groups, multi-specialty, subgroups, and APM entities. In 2026 and on, they're going to take away that multi-specialty option and force clinicians to form subgroups. Again, I'm not going to get into the details of what a subgroup is since this could all change in the upcoming years, but the idea is that you could form and report a subgroup based on your specialty or the conditions that, a group of your providers treat within your tax ID if you think you're going to score better. Really, the whole idea is that you can form specialty specific groups to try and make your lives easier and your scores higher. Now, again, the whole goal is to combat feedback CMS had been receiving when practices said things like there's too much choice and complexity when it comes to picking our measures, or, my favorite when they said, and it's true, that measures and activities aren't always relevant to your specialty. So the idea CMS had is, well, let's limit their options and tell them what activities and measures to report on that pertain to your specialty or the conditions you treat. Now, what I do want to note is this quote from CMS in the box, basically stating that they have not finalized the sunset of traditional MIPS yet. There is no date or end date that you are forced over to this MVP track as of now. I would keep an eye out for it, but again, we're still fine in traditional MIPS as is. Again, here are the MVPs that are available for 2023, and they did propose 5 new ones for this year as well. And again, I'm not going to talk through this slide too much. It's more of a visual example of what the MVP structure looks like. So you can see quality measures are aligned with improvement activities and cost measures, all based on what the value pathway focuses on. So you can see this one's diabetes prevention. You've got, quality measures only associated with diabetes. Same thing with improvement activities and cost. Also, I'm not going to spend a ton of time on the reporting side of things since, again, I have a feeling this could all change. But to kind of break it down, quality, you would only have to do 4 measures, no longer 6. You would still have to do your PI data unless you were exempt. And then there is 1 population health measure. You would still pick, 1 to 2 improvement activities, and then you would still be scored on any cost measures associated with your MVP. So again, I think you can see why I'm not calling this a program overhaul, more like a reorg. And I would be remiss if I didn't take this last minute that we have to remind you to preview your 2021 MIPS scores. CMS started a new preview period for your final scores this year to make sure that scores are correct before releasing payment adjustment information. Genius. So I encourage everyone to log into your QPP portal and review what your current preview score states and see if it looks correct. Your final scores and payment adjustment information should be released later this month. And if you're like me, I had trouble logging into my QPP account and had to call the help desk. So now is a great time to get that taken care of before your final scores and payment adjustments are released. And that's it. You made it. I would say next steps would be, visit our website, continue to sign up for these webinars. If this did seem very overwhelming to you, if you'd like another set of eyes looking at your data, if you want us, someone to completely take this over for your practice, please consider working with our government incentives team. It's just myself and Kimmy and Bridget who are on the line to answer questions today as well. You'd work with us directly, and we try and make your lives easier. So again, you can reach out, if you are a current DAS Health customer, you can reach out to your DAS Health account manager. If you are not a current DAS Health customer, feel free to just email me directly, and you can see my contact information on the screen. So I will turn it over to Chelsea for questions. I know we only have 3 minutes left, but I think our team can stay on the line for a little bit longer if needed as well.
Yes, thank you, Lindsay. And we do plan on staying. Hopefully it shouldn't be too long, but we do want to go over a number of these questions. And Kimmy and Bridget, sorry, I forgot about that for a second. Kimmy and Bridget did a great job answering many of them live in the moment, but I'm going to go ahead and read them out loud anyways, because I think that they have some value and a number of other people might have the same questions. So I'm going to start with this one, the first one we got. If we report high-risk meds in the elderly for 2022, this measure does not have a benchmark, so it would be worth 3 points. I've read that if they can benchmark with the data, they will. Can you elaborate? Kimmy, can you elaborate?
Yeah, absolutely. So if your practice is reporting on this measure, CMS can't, if enough practices are reporting on this measure, CMS can release a benchmark, allowing us to gain additional points for that specific measure or any measure that has no benchmark. So to your point, absolutely, yes, we can get additional points if more practices report on that measure when it comes time to submit your data.
Great, thank you, Kimmy.
A
Oh, go
great point.
ahead.
I can add to that, Chelsea. Sorry. So great point. Last year didn't have a benchmark, and CMS did actually go back and create a benchmark for 2021 reporting. So that's an instance where we might report for you a little bit more than just your top 6. We might include, maybe 8 measures for you because those 2 might not have benchmarks, but if they create benchmarks, they would get scored. So that's a great call out.
Great, thanks for that, Lindsay. Next question. I think I heard Lindsay say that small practices are auto-opted out of PI reporting. Is that correct? Why would they be opted out of that category? Bridget, do you want to take that?
Sure, I will take that. So yes, for small practices, which is, for your practices that are 15 and under clinicians, previous years, a lot of practices were applying for the hardship exception for the PI category. So this year, CMS has gone ahead and done a blanket automatic exception for this category for small practices. So you have the option to report if you choose to, but you are not required to.
Great, thanks for that, Bridget. Next question. So can you submit both INDV and group data? How does that work? Bridget, can you grab that one?
Yes. So for individual and group data, can you submit both? And the answer is yes, definitely. MIPS eligible clinicians can report data as an individual and part of a group under the same TIN. And this is really good news because if you do participate as an individual and as a group, CMS will evaluate both scores, and then your payment adjustment will be based on the higher final score. So it's a great option and a great way to report.
Great, thank you for that, Bridget. Wow, that was a great presentation full of lots of information. If we wanted to possibly hire you to assist us, does it matter what EHR we are on to get your assistance?
Yeah, I can grab that one. Well, thank you. That made my day. It just keeps me propelling into having more horrible jokes in my presentations, everyone. But no, so it's a great question. No, it actually doesn't matter what EHR you're on. I believe, and Kim and Bridget, correct me if I'm wrong, I think we're up to maybe 13 or 14 EHRs we're assisting clients on right now. We definitely have deeper expertise into certain ones, specifically probably NextGen, a Prima, Athena, ECW, and even Metasoft Clinical, Litech, things like that. But even naming those all off, the short answer is no. It does not matter what EHR you're on. We're very used to getting in there, mastering it, and helping you out, and providing that program expertise that you need to really navigate this.
Great, thanks, Lindsay. Next question. I just looked up my providers and they have multiple practices listed besides just ours on the NPI tool. What does that mean? Kimmy, can you answer that one?
Yeah, absolutely. So that's a good question. So first step that we want to look at is your eligibility, right, for any NPI or TIN. So that would be through that QPP lookup tool. So we'll take a look at that and see, what your eligibility looks like. And then if you have reassigned any kind of billing rights to multiple TINs, you'll see all those associations to those multiple practices within the QPP participation status tool. So we'll take a look at your eligibility. We'll look at the different combinations that you have, and ultimately you'll receive any kind of payment adjustment based on that TIN or NPI combination where that low volume threshold was exceeded as either the individual, if that's what was submitted, or at the group level, looking at that group reports data. You won't receive a payment adjustment for any associated practices where we didn't exceed that low volume threshold, or if you had previously excluded from MIPS.
Okay, perfect. Thank you. Lindsay, I'm going to hand this one off to you, but it might be a little bit too practice specific, but I'm going to go ahead and ask it anyways. What if we can diagnose an item on our state's case reporting list, but we barely do it? For example, we have diagnosed and or sent someone for testing to see if the patient has TB due to things that are going on in their eyes that we evaluate. Can we still claim that exclusion?
This is rough. I help a ton of ophthalmology clients, and this has been popping up with that specialty specifically. So unfortunately, the answer is no. If you diagnose and treat any condition on that list, you would be required to report. So what your next step would be reaching out to your state specifically. So if you're wherever you found that list, there should be an email or a phone number. You might get bounced around, but you'll eventually find someone. And I would ask if they're accepting data specifically on TB, because what we found is that most states then respond and say, nope, we're not actually set up yet for that diagnosis, or nope, unfortunately, we're only collecting COVID-19 data at this time. So the majority of my ophthalmology clients, I think all of them, we've gotten them excluded, even though they do diagnose or treat conditions on that list, because they've taken the extra step and reached out to the state. And then you have that email on file to save for an audit. So that would be, my recommendation for your next step.
Great, thanks, Lindsay. And this one's a little bit similar, so I'm going to follow up with it. Regarding the ECR, if we diagnose a patient with a disease based on lab work or imaging on the list, but refer them out for treatment to another location, would we still need to report for ECR? We don't do continued treatment on the patients for diagnosis on the list.
Gotcha. Yep, I hear you. But CMS's verbiage is diagnose or treat. So if you are going to be the first clinician to diagnose this patient, then you would have to report that data. So again, same idea that I just explained of kind of your next step, reaching out to the state on the specific diagnoses that do apply to you. But yes, if you are going to be the first provider to diagnose this, it would need to be reported technically from your practice.
Okay, great. Okay, next question. Is it true that for 2022 on the PI CAT HIE, you attest both HIE 1 and 4, submit 1 as proof?
I do not have the specifications in front of me, so I don't know which one's HIE 1 and which one's HIE 4. The only thing I'll speak to then is, so for the HIE measure for this year, you can submit both HIE receive and HIE send, or claim an exclusion if you're under 100 for either of those. And you do have for 2022 a third option. It's called the HIE bidirectional measure. If you submit that measure, it's actually a yes attestation measure, whereas the other two are data driven. You're attesting that yes, you perform those activities. You'd have to look up the spec for exactly what you're testing yes to, but then you would get full credit for that measure just by doing that one option versus HIE send and receive. So I hope that makes sense. You've got two options: submit, receive, and send, or just submit the HIE bidirectional for 2022.
Okay, thanks. Next question, and we're getting towards the end here, so hang with us. What survey IA measure have been removed for 2022? It looks like EPA 3 is still active. Is that correct? It's very similar to the one that you referenced has been removed.
Yes, great call out. So there were two survey improvement activities. I don't have, like I said, unfortunately, I'm sharing my screen with you guys, so you see everything that I see. So I can't quickly look it up and Google it, but there was one survey-based improvement activity focused on beneficiary access or engagement. The other one was focused on beneficiary engagement, and the other is focused specifically on access to care. So it was a little bit different. The beneficiary engagement, I believe the CMS suggested documentation for that one was a little bit more open-ended on patient feedback. The survey focused on actual access to care, I believe, has more specific guidance from CMS that they're looking at. What the patient's experience was trying to access your care, or schedule an appointment or get with a provider, et cetera. So there is still one available, but again, I would recommend that you go to the QPP Resource Center and download the validation zip file and look at the improvement activities CMS suggested documentation, and you can compare how they're different.
Okay, last two questions here. Will there be a PDF copy of the presentation for us to keep? I can answer that one. Yes, there will be. I'll be sending out a link to the slides and the recording within the next week, so definitely keep your eyes out for that. Sometimes, for some reason, it goes into people's spam boxes, so if you haven't received it, always feel free to reply back to the email that had the confirmation that you used to log into the webinar, because that comes to me, and I can send it to you that way as well, or really any of the communications with us. Find a way to reach out to us, and we'll make sure you get it in case something happens and you didn't.
Low-hanging fruit, Chelsea. You're no better than me.
Okay, so last question. Where would we find the benchmarks?
Oh,
Bridget,
I can take that. This is Bridget. Yeah. Actually, I'll go through that and kind of mention as well what happens if there isn't a benchmark for a measure, because we got a couple questions regarding that. So I'm just going to, we'll combine both answers. So first, to find the benchmarks, it's going to be on the QPP website. So the website is pretty easy. It's qpp.cms.gov. And then when you click on there and you're on your home page, at the upper right-hand corner, you're going to see a word. It's going to say resources. It's bold. You click on that, and then there's a drop-down menu. In the drop-down menu, you're going to see resources library. When you click on there, you can search for anything. And one thing I would recommend searching for is benchmarks. Just put the name benchmark in. And there you can download the 2022 benchmark zip file that is available. So that's right there under resources, resource library at the QPP website. So I wanted to go through quickly. I'm sorry, go ahead.
No, go ahead.
Oh, okay. Quickly too, if there isn't a benchmark for measures, so we have basically seen that the past couple of years, normally we're going to have a range of 3 to 10 points for your benchmark for your quality measures. But recently, if you found a measure and it doesn't have a benchmark or it's new, and new means that it doesn't have any historical data to compare it to, CMS will have that. They'll look at that measure and they'll have it at 3 points for now. But what they'll do is they'll also look at current data for this year instead of past data. And that measure may get an increased score, but you do not know until you submit that data. So benchmarks are very important because they control your quality score. And CMS has been known to change the benchmarks during the year, throughout the year, a couple times. So our team, we monitor the benchmarks closely to make sure that we're choosing the best measures for our practitioners and providers to report. Because you do not want to have measures that are only worth a few points, since we no longer have the bonus points that Lindsay had mentioned earlier. So I just wanted to bring that to everyone's attention as well.
Awesome. Thank you for clarifying that. It looks like we have 2 more questions, so we're going to go through those here. If we claimed an exemption from the PI and IA, then are we scored for quality, or do we just receive the default score? Can you confirm that you must submit data for at least 2 categories to be eligible for bonus for 2021 reporting? And does this requirement hold true for 2022 reporting?
That is a seasoned MIPS vet right there who answered that, who asked that question. So great call out. So what you're referring to, I would assume, is the COVID-19 hardship that allowed you to claim, a hardship for all categories. But what it also did, and a lot of people didn't realize, it would allow you to claim a hardship for 2 categories and then still report on 2 categories and get a full score payment adjustment. So your understanding is correct. If you claimed a hardship for PI and IA, then you would have been scored if you submitted data for the quality category as well as the cost category. And you should be eligible for a final score and a payment adjustment. The only thing I would say, to be cautioned of, they have in the past said they aren't going to score cost. So if for any reason they came back and said for 2021, you know what, we're not scoring cost, technically you would have only had 1 category's worth of data submitted for quality and you wouldn't get a final score. The same idea here, they did release a COVID-19 hardship for 2022 with the same, specifications or guidelines. So you are correct. You could technically be exempt if COVID-19 is still impacting your practice. And we definitely recommend to make sure you have documentation to back that up in case of an audit. But you could actually submit data for only 2 categories and get the full score payment adjustment.
Okay, perfect. And drum roll, please. Last question. Do you have any information regarding the performance improvement bonus point in the quality category? Mainly, how is it calculated?
I can jump in here, but Kay and Bridget, feel free to jump in. Basically, what happens is in the quality category itself, if your quality score improves, year over year, they calculate a certain percentage and add that improvement score towards your quality category final score. The specifics of exactly how it's calculated, we would have to look that up on the CMS website. Kim or Bridget, you don't have any transparency into the specific. I mean, that to me, it's probably going to be some sort of math equation. But some ideas, some ideas here. Just know if your quality score, category score improves, from 2021 to 2022, you should see, some sort of bonus points added to your quality score for improvement. They historically haven't been very big.
Yeah, specific on it.
If I'm correct in how the equation works, it's very similar to any kind of bonus points. So, you know, how you get your quality sum of points for each of your quality measures. If you have any bonus points, that gets added in there. And then if you have the improvement bonus points, I imagine that would also be where it would be added in and then, you know, multiplied by the or divided by the total quality points and then multiplied by the performance weight. Math.
Math.
Perfect. Yep. Yep.
Okay. Anybody have anything else to add? Lindsay, Kimmy?
I would just say thank you all so much for hanging in there. I mean, we're 15 minutes over. I appreciate it, but we really wanted to make sure we got all your questions answered. Again, my contact information is up on the screen if you have any follow-up questions or if you're interested in working with our team. I think you can tell we are a ton of fun, and I promise to keep our lame jokes at a minimum if we are working directly.
You do not.
But I highly doubt
You do
it.
not. You won't. You will not. Don't listen to that. Well, thank you, everybody. And please, for those of you who joined us through Attentive, please, please, please remember to start following us at DAS Health. Keep your eyes out. You already probably saw that this email came from us with that name. So start following us on those socials, on those platforms, and with those emails. We don't want to accidentally lose contact with you somehow. So thanks for joining us today.
Thank you.